So I tell people about it, like if it ever happens, you would try that.
Right, you start clicking all the buttons.
Huh?
Start hitting all.
Yeah,
the
hit all the
buttons.
buttons.
Something's gotta work.
Anytime you guys wanna start, there's a good crowd online.
Okay, well then maybe we'll just get.
Yeah, let's start.
That way.
Yeah, good.
Okay, well, welcome everybody. Thanks for joining, both in person and online. We're excited to welcome our speaker for today. I'll introduce Tuhin in just a moment. I did want to just let everyone know that we have some upcoming talks. We've been fortunate now to schedule out our entire rest of the academic year, so you can book your calendar for all of these events. So let me show you here. Here we go. So here's a rundown of all of our events.
Hello.
And all of our presenters. So you can see we go all the way through the 17th. We have some external, mainly internal folks talking, some within CHS, some outside of CHS. Hopefully you have calendar invites in your calendars already for all of these events. Otherwise, please mark your calendars for some of these. And I do want to emphasize, we're trying to make this more of a expected cultural thing. After all of these events, we go out and have drinks. So
That's why I'm here.
yeah. Thanks, Dorothy.
Call me out by name.
Yeah, so if you're online, next time, join us in person and if you can. And we all just go out informally and have drinks on a Thursday afternoon. Our next speaker is our very own interim dean, Michael Udell. He's going to be talking about some of the challenges that our public health system faces. And that will be a special event because there will actually be some snacks and little food and things during the happy hour afterwards. We're going to do that one at Thunderbird at the bar. And so there'll be some light snacks and things. So please mark your calendar for the 12th to try to be in person. It'll be a great chance to see everyone kind of one last time before kind of people depart at the end of the semester. So on that note, I'd like to introduce our speaker for today, Dr. Tuhin Sheikh. So one of the reasons we do these innovation talks is to bring in some of our newer faculty so that they can get to know all of us and we can get to know all of them. Tuhin is one of our newer faculty, so I'm going to just briefly introduce him and then he can come up and give his talk. So he's an assistant professor in biostatistics here in CHS. He came most recently from his postdoctoral fellowship in the Department of Biostatistics at Yale. And prior to that, he did his PhD in statistics at the University of Connecticut. Finished that in 2022. So he's like fresh from Connecticut in Arizona. So he went from nice weather in the summer to nice weather in the winter, I guess, but how to make it through our summer this year, so. His research interest, which I've just had a nice conversation with him and got to know more about it, is on competing risks, which he's gonna tell you about, and semi-competing risks in survival data analysis. Also longitudinal data analysis, joint modeling of longitudinal and survival analysis, survival data together, which I think is fascinating. Also, Bayesian computational modeling, and he has experience with the UK Biobank, all of us, electronic health records, cancer, type 2 diabetes, statistical genomics, microbiome data, all things that we as a college do a lot of. So I think it'll be really great to hear from Tuhin and hear about the work that he's done and then brainstorm some ways we can all work together. So Tuhin.
Thank you so much, Matthew, for this nice introduction. And as Matthew already introduced me. So before I just jump into my formal presentation for today, so I picked up a collection of my work that I have done during my PhD or my postdoc, and I'll just try to wrap up a few things together So before going through the formal presentation, just wanted to introduce myself to you. I started my career in statistics in the University of Dhaka in Bangladesh. So this is my home country. I did my bachelor, master's there, and then joined as a faculty, worked there for 2 years. And then I realized to do advanced statistical work, I need more training. So then I joined this nice school, University of Connecticut. It was in the eastern side, so you can imagine. So I spent around 7 years there. So when I came out from the Sky Harbor, it was just like an oven. So it's pretty horrifying for me and for my wife, but it's been great. So after doing my PhD, I went to Yale in the Department of Biostatistics to do as a postdoctoral associate. And for my PhD, although I started as a core statistics, very dry, then I was lucky enough that I started my work with the health science data. So previously, like the culture has been changing. In stat community, we usually start with some method, then we try to find out what are the limitations of those methods, and then develop new methods. So this is how the community worked for many years, or in other sense, it's pretty dry. So now, as the influx of data coming in, now the situation is changing because you develop a method and you go to the real world, like UK Biobank, nothing works. So now we go differently. So we start with the data, let the data to talk, and then as a statistician, I help the data to talk using my method. So that's the reason I joined Yale University in the biostatistics, because at that time I felt, okay, so I got some of the area where I find interest, and something I can also say I'm not just only contributing method, I'm also contributing to the health science that is helpful for this community. So from Yale, then this is something matched with me, the health solution at ASU. So that this is how like my trajectory come in. So now let's jump into the research that I'm going to talk today. So this is when I started my PhD, we came across some large data sets, not that large because later on I came to know what is large. Like it's not 500,000, not 1 million. It's around 35,000 subjects, but not that bad. So I started with the prostate cancer data. I started learning what is prostate cancer. Like from the biological side, you can see that just near the bladder, there is a gland. It's called prostate. So there is a cell. It's called carcinogenesis or carcinoma. There are two types of terminology. So when you have many cells jumping in together, and then it starts like a mold, and as big it becomes, the more problem you're coming in with. So then we call this cancerous tumor, and then it's called prostate cancer. So the data set, so this is not my picture, so this is like collected from American Cancer Society. So I apologize for these images. I spent a lot of time, but when we changed the computer, everything just went down. But for those the data sets, we have two primary outcomes. So one is the longitudinal outcome. So all of you might be familiar with the biomarkers. So for the prostate cancer patients, prostate-specific antigens is their primary biomarker. So there are other biomarkers as well, but this is something that clinicians try to evaluate over time. And also we have the survival data. So the survival data in the real raw data, it comes with different dates, like the starting of the study, when they were the test happened, then the results, few things, just here and there. Then we have to work a lot to make this data clean. So just to give you just an idea like how this data looks like. So we have the prostate cancer status at the end of the study. So this is a very honest picture. I didn't manually pick any subject. So this is, I just asked our software, give me a few random numbers, and then I just want a picture. Because sometimes I heard a comment from one audience, did you selected those IDs just to show us that those trajectories look like this? I did not. So these are two classifications. Like on the first one, these did not experience any prostate cancer. And if you see their trajectories, you'll notice two different things. The slope means how steep or over time how they're moving. It's almost flat except one or two. Even one or two, the red bar, this red bar is the value of PSA or prostate-specific antigen 4. So 4 is something clinicians always just like a red mark. Like if it goes beyond 4, then you have to be careful or take suggestion from the doctor. And on the right hand side, you can see that the starting point for most of the patients are slightly higher, like from 1 or from 2 or 2.5 or somewhere, and then it starts going up. So this is something that we want to capture. Can we capture like when this PSA is going up, how worse it is in terms of the risk for the prostate cancer development? Yes.
So on the top, I see that 0, 2, 4, 6, 8. Are those like months or what?
Well, these are years.
Those are years, okay.
Yes.
And going off of that, what's the green line represent?
The green line, you can ignore that because, but the green line is what is the last episode of data we have. So I just kept it just to have a good summary of the subject, because some of the subjects we may have only 2 years, only 3 years. So this gives you the exact time, like how much we have. So since we may have many new audience who don't know what is survival data. So for the survival data, what we do, we start with a study. We have a starting period or follow-up period. Then we start follow them up. Like just imagine you go to the doctor asks you, come back after 3 months, come back after 4 months, something like this. And then he gives you some test like blood or something, then something happened. So this is called event. So for our case, it's the prostate cancer. So A and B, these two, we can see that event happened, A, B, and F. For the rest of the 3, the blue colors, even the study ended, nothing happened, or the subject dropped out. At the last time point we saw that nothing happened. So those are called, in the terminology of statistics, we call them censor. So they didn't experience the event or they drop out of the study without experiencing anything. So now the new challenge coming in this data is that, like when in the prostate cancer clinical studies, they, in addition to the PSA, when the PSA going up, they need to do the testing. It's called benign prostatic hyperplasia. So that's a very complicated term, BPH in short. So this is like a confirmatory test. So whether a subject really had the prostate cancer. There is another test, it's called DRE. It's called rectal, yeah. So these two are like confirmatory tests. When subjects go through those tests, they're also evaluated on the score, is called Gleason score. So this score gives you the idea how intense is the prostate cancer. So it's something that I didn't make up. So this is based on the clinical study. So there is a category, like if it's below 7, it's called low grade. It's over 7, it's called high grade. So if you have nothing, it's unknown grade. So this is, I made up, it's unknown grade. I don't know the grade. So in our real data, I have 2 information. One, those subjects were diagnosed with prostate cancer. I don't know the Gleason score. So in a sense, I don't know their grade. And you can imagine this data slightly differently. You can imagine that subjects are these causes, like low grade and high grade. If you consider these 2 are causes, one cause is competing with other, and one happens, other doesn't happen. So this is in survival world literature, it's called competing risk. So you have risk of the event due to multiple causes. So you will experience only one, you will not experience both, something like this. So in the risk assessment study or literature, people always try to, are interested. So if maybe some of the covariates may be associated with one cause at a very higher degree or intense, may not be the same with the other causes. So instead of like considering all as prostate cancer, so we can classify or categorize their survival time to develop prostate cancer due to low grade or due to high grade, or we have the complication, we don't have grade. So this is something we got, it's pretty unique at that time, that there is nothing or no existing method that can analyze those kind of data. So what to do? So this is, I just kept it just for the Q&A, some basic summary of the two trials, PLCO and SELECT data. I will go back to this later if we have time. So this is an interesting, a very interpretable graph. So these are the survival probability. So it's like, just imagine we have the lights. So lights have, survival, that they have a life. So you go down, the survival probability will go down as well. I mean, you go follow up a longer period of time. So for the subjects, it happens the same way. You go forward with the time, the survival goes down. So the thing is, we have three colors, or I can say the bottom one, this is the high grade. So they have the least survival probability over time. And the top one, or the green one, is the low grade. And this one, unknown grade, it's just like matches with both or in between. Because when I talk with the people who know the trials better than me, because who were involved with the trial, so they said this unknown grade is a mixture of low grade patient and the high grade patient. And they dropped out of those studies for multiple reasons. So they didn't like it. They wanted to go to different clinicians without informing the trial and many other things. So this is another picture. Although it might be slightly difficult to understand, but instead of, as I said, one audience told me you didn't select some subject to show us that it has something, some fact. I didn't select anything. So this includes all the subjects, no selection, all. And if you just imagine at different time point, PSA was measured, some are very diverse values. So the logarithm is a function that shrinks the values without changing their interpretation. So it just something you input 100, it becomes only 1.5. And if you input another value, 100.1 or something, it shrinks to another unique continuous value. So this logarithm helps us to, maintain some of the assumption of the statistical methods, and also helps to visualize the data. So for the no cancer, it's just like a flat line. There is no increase, almost a very horizontal line. But for the other groups, there is a slightly increasing pattern. But from this graph, it's very hard to see because it includes all the subjects together. So let's move on. Yes.
Can I ask a clarifying question? The unknown grade, is that a time invariant construct, or like at the beginning, their grade and they've been unknown throughout, so they sign up for the trial, but you never have a chance to get their license for it? Okay.
So I have three aims for this research. The first one is finding the association between the longitudinal PSA or prostate-specific antigen and the survival to prostate cancer due to different grades. And here in the middle, you can see we have the subject-specific random effect. So just forget about the terms, that's okay. Just imagine subject-specific random effects. So each person is different. Their trajectory is different. So if you just build a common model that works for all of them the same way. It doesn't work. For each subject, there is a unique randomness that needs to be captured. So I will talk more about it. So in other way, if you just disregard it and just do survival analysis, consider the PSA the same way you have the body weight, height, and other variables, it will disregard the probabilistic nature of the PSA. So PSA is something you cannot predict what is going to happen. In fact, you can let other variables to help predict PSA. So PSA in statistical term, we call it probabilistic process or mechanism. So if you just disregard the subject-specific randomness, is disregard the probabilistic mechanism, and it will impact the statistical inference. Yes.
I just want to make, again, I apologize for just stepping in, but I mean, if you've got longitudinal data, wouldn't just an individual fixed effect account for subject-specific random effects instead of doing a random effect model?
I don't understand.
Like an individual fixed effect per individual, just with your longitudinal
Then
data, that would be, I
There,
think, more effective than just putting a random effect.
then it would be more like a time series model. Like for each individual, you have a temporal data at different time point. So this fixed effect wouldn't work for the population. It might work for one subject. So if you want to gather all the subjects together, that there is no way you can fit a fixed effect. You can, but it will disregard the subject-specific randomness. It will no way capture that variability.
Trade
I'm
off.
not sure I understand, so I'll let you follow up.
Yeah, so I mean, on population data, you don't have a fixed effect for everyone, right? You only have it for people in your sample. And so making projections, requires the assumption that the fixed effect then becomes zero. But random effects have a very binding assumption that the random effect is not correlated with any of the other variables in the model, which is
Yes.
almost never the case in most research
It
projects.
can be, it can be. That's why I'm
That's
here.
a really strong assumption.
We're not saying it can't get published, we're just
Right.
saying whether we believe it.
No, you just need to know.
All right, keep
how to
going, keep
fix
going.
this assumption.
You don't have to get hung up on this, but traditionally I would like to see an individual fixed effect longitudinally. And you can argue you can't extrapolate it out, but that's actually not the point. It's the mediating effect on the other covariates. So we can believe that they're credible covariates, given that there's a lot of individual fixed effects that are commingled inside that overall regression.
I can come up with a discussion, but I have the answers to all of your questions.
Oh, please.
Yeah, I'm pretty confident on that. So my next aim is like I developed new method. So how can I convince you that this method is good? So you need to have assessment or evaluation criteria. So these are I'm sorry about the resolution. So when we changed the computer, resolution went down. So there are two kinds of assessment tool. One is called concordance index, and another one is very limited in the Bayesian framework. This is called, like if you have heard about AIC, BIC, this is called DIC, deviance information criteria. So this is something we develop. I will talk about it. And the third aim that I pointed out in our research is like we have two trials with a similar type of goal on the prostate cancer subjects. So whether can we use one data to help the interpretation or analysis of another data. So this is another regime of research. This is called full data analysis, full coming from complementary data. So you have multiple data with similar structure, similar hypotheses can work together. So I will also talk about this briefly.
Can I just ask for one more clarification? So you're calling this competing risk survival? And it's the risk of study non-participation?
Risk of prostate cancer.
But the competing part, what is it competing with?
So it's like,
Alternative, like attrition from the trial?
it's like a subject can get the event due to one of the causes. So these two causes are definition-wise like competing with each other. You'll just get one. The first one or the earliest one, this is the event we call, and the cause we name them. But literally, it can happen by any one of the causes. which are just like competing each other. So this is the term that has been used in the statistical literature for a long time.
Okay, I have a question. I think, oh, sorry.
No, go ahead.
I think one of the things that, the way I've heard or conceptualized competing risks is actually close to what Marissa's saying. It's the risk of an alternative event happening that prevents the participant from actually getting to that end prostate cancer diagnosis. Is what you're saying, it sounds a bit different, so I'm curious about
No,
what
I-
you see as the differences between these.
I think you said it nicely. So like it's happening one way and preventing the happening of other. So this other one is the competing cause. So that is what I'm saying. The event is the same event. So the event can happen due to different causes. So an easier example could be like death. Death is my event. So death due to prostate cancer, death due to breast cancer, death due to different things. So all these are causes, but you cannot have multiple causes at the same time. There's always someone beating other. So something happening earlier. So this is something like definition wise. We call those causes as competing causes. All right, so these are the three. I'm really sorry about this. And also I didn't want to talk about the math in this talk at all. So this is something, it's called joint model. It's like some of the discussion that we are trying to have, like can we use the longitudinal covariate in the survival model just as a fixed covariate and without just considering any kind of thing. So there is a very line of work that showcase that if you just disregard those interdependencies between different processes, your statistical inference could be impacted heavily. So this is something we developed a new joint model where the subject-specific randomness is shared between two types of models. So let's skip this kind of first for now. And since we also have some of the data that we don't know the cause of a group of subjects. So within the Bayesian framework, we derived the probability for those subjects who are diagnosed with prostate cancer. So what are the chances to be diagnosed with a low grade or high grade? So this kind of thing we derived. And let's skip this. And I just kept it just to give you some understanding. The background of this analysis, there are several things going on in terms of statistical inference. So for this work, I did using the Bayesian framework, but there is no, discussion or controversy like why Bayesian, why not Bayesian. That's a different discussion. But this is something we utilized in our work. All right. So let's just focus on few of the findings that we did. So one is, so there are alpha parameter on the right. So you can forget about alpha. Just imagine this is the association parameter between the prostate cancer and the risk of the event that we focus on. And the alpha 2,2 and alpha 1,2, this corresponds to the slope parameter. 2 represent the high grade, 1 represent the low grade. So it showcased something like for the high grade subject, the association with the PSA slope is slightly higher compared to the low grade. And also, surprisingly, we found the intercept for the low grade is slightly higher than the high grade. So that implies that for the subjects who developed low grade, their starting point, this intercept is something, what is at the 0 time point, what was their PS? Was slightly higher, but over time there's the slope for the high grade was slightly steeper compared to the low grade. So, and since we developed a new method, it's very hard for people to convince that whether it should work for any kind of situation, because I did it for one data. So simulation is something that can help you to understand. So mimicking the same situation and generating the data from a population point of view and just showcase that it is working and it is giving you the true values of the parameters that you are imposing on the model. So this is the bias of the parameters we had in the survival and longitudinal models that we developed, and all are very close to zero, and we don't expect to be zero because there will always be some kind of randomness when you do the simulation. And this is called the coverage probability. So this is something like you specify one true value in the model, and then using the Bayesian framework or just the typical frequentist framework, you always calculate the confidence interval. So it's like calculating the confidence interval every time and then checking whether the true value is included. So if you do it 1,000 times, theoretically we can show that you should get around 5% error or 95% true coverage. So if you get something very close to 95%, so that is reliable, that we get cover almost 95% times when we do the simulation, and this is covered. So we did publish this paper in statistical modeling, and then we actually came up, yes.
I assume you're gonna tell us something about beta 2 too, which seems to break both of your tests.
Which one? Oh, this one?
Yeah.
Excellent point. So this is the simulation we did for 10,000 sample size. Actually, for the paper, we did 10,000, 15,000, 25, 30. So when we increase the sample size, then this beta 2.2, it becomes close to 91%. So, but for the main paper, we didn't show up the higher sample size. We showed the smaller sample size that gives us quite okay. I mean, if you go increase the sample size, then the precision increases, and the binds or the intervals becomes narrower, and we get better.
What's the covariate associated with that?
Which one? Oh, beta 2.2. So this is simulation. You can consider any kind of covariate. So we just generated from normal distribution, this one, but it can be any. So then we started working on the model assessment tool. So I just didn't know how should I put it. So there are a lot of formulas there. And then we actually developed two theorems. It's called deviance information criteria. So usually what happens for the deviance information criteria is always like one deviance information criteria, irrespective of the causes. So we wanted to see, and also one of our co-authors who also did quite a few works on this prostate cancer, he also shared one comment that whether it's possible that we can have the assessment criteria for different causes. So might be some of the covariates associated with one cause, maybe some other covariates associated with another cause. So this can also be helpful for variable selection and some other purposes. So we developed two criteria. One is called deviance information criteria, and another one is called concordance. Concordance is actually popular in different fields, especially in the machine learning world. Many people use the concordance. It's something like, suppose you have the observed survival time A versus B, one is smaller than the other. If you calculate the survival, you get the concordant picture. So this is how it works. So when we started working on especially the concordance, we became very frustrated because for even only 35,000, we need to calculate multiple pairs just to find out whether it's working for all pairs in the same concordant way. But even for 35,000, it was taking very, very long time. Like if I go to the UK Biobank, then it's going to be a nightmare. So then we actually, always problem is good, because if you can come up with a solution, you can write papers. So me and my advisor was really frustrated, so that's not going to work. We cannot let the reader or the user wait for 3 days to get this index. So that's not work. So then we developed a theorem. And then instead of doing all the pairs, we can jump and and go for the unique event time. So there are a lot of discussion behind it. So I'm just going to skip it. So just give you some of the results that we have. So for the DIC is smaller the better. For C index, higher the better. So we try to mimic the simulation in a way that imagine that we have a discussion a few minutes ago that we don't consider the prostate cancer, prostate-specific antigen as a longitudinal, just consider as a fixed. Then there is no need to do the association together using the joint model. And other one is generating the data from the joint association and then try to calculate the DIC. And we can see that for the right one, this is using the joint model, and this one without considering the joint model. Just consider this as a fix. Then we get a jump on the improvement of the DIC that it lacks the fitting, even if you may not see it, but it lacks some fitting. And also we find consistent information or conclusion from the data analysis similarly. So we get similar findings for the C index using the data, real data, and also using the simulation study as well. So we could publish this paper in the Statistics in Medicine journal. And also I got a award in a conference for this paper. And then we have 10 minutes, okay. So finally, we thought there is one audience who asked me, if you have two data sets with similar style, similar philosophy, similar goal, why don't we just merge two data and just consider those two data a single data and just analyze? So you can think of this as a provoking question and then think about this research. So we can only do that if these two data are almost identical. These two data has the same style, same characteristics, same timeline, many other things. But in real time, we cannot guarantee that. So that's the reason I kept one slide of two data, some of the summary. So there is a line of work in this area. So what to call core data, prior data, historical data, concurrent data. So there are many things. So we try to develop something in that line because in the joint modeling framework, the model itself, it has multiple parts. So the first thing, something is called power prior. So it's like you have the current data, the data you are interested in, and you have other information as a historical data, prior data, concurrent data, core data, whatever you call it. So now you will always want to be have your current data, the dominant one, because this is something, the data you are interested in. But you have some information from prior study, historical information. You want to take some of the information, how you're going to do that. So this is something we do it using power prior. We give some benefit of the prior historical data using some parameter. So this is there is one tiny A naught or something. Just imagine one influence parameter. So this parameter can go from 0 to 1. So if it is 1, that means the first provoking question just merges together and just analyze as it is. But as it's going below 1, that means you are giving some weight to the prior or historical data. So it is influencing your interpretation or inference of the current data. You are controlling some way, using some weight. So something similar, the way I'm trying to say, we develop using the joint modeling framework, since we have multiple parts of the model. So we found that we just name it a very fancy name. It's called borrowing by parts. So for different parts of the joint model, you can borrow differently. And your ultimate goal is to have few things like improve the fitting and also improve the precision, because at the end, you want to talk using the interval. For your case, if you're familiar with confidence interval, or for the Bayesian world, we call it HPD interval, same thing, almost similar thing. So let me show one figure, because I don't have a lot of time. So we try to analyze the data few different ways. First, we did not borrow at all. Then we try to borrow all together for different parts, no different, all parts, same influence. And then we borrowed by different parts differently. And we found that there is a nice harmony that depending on the data. So this might not work for all data the same way. You have to evaluate, or you have to just do trial and error. Whether it's, and also I'm actually working on something regarding this work so that it help the user. You don't have to try a lot. Maybe we can give you a method that can help you to find out an optimal value rather than going through trial and error. Okay, so I have prior data, how much is going to influence. So there's some of the interesting message that if you have a concurrent data, don't trash it. If you think that it has similar style, structure, we can try analyzing, keeping the main data or current data dominant. This information can also be helpful. So this is a greater message. So we published it in Statistics in Bioscience Journal in 2022. So 5 minutes should be good. So this is an interesting concept I just learned very recently. I didn't know about it. Just theoretically, imagine that you have a follow-up time or study ending time here. This is dotted line. And you find that C, D, E, these subjects did not experience the event. And in your data set, you will write censor, no event happened. But imagine just if you could extend the follow-up, maybe 4 years or 5 years. Some of them may end up getting the event, and some might not. But if you go towards theoretically infinity, maybe you just keep on following and nothing happened. So for those, we call it getting cured. For those subjects, it is not possible ever to get this disease again or this event again. So another way to find it out is like if you see the survival probability, and theoretically, if you increase the follow-up, the survival should go down. Just imagine the light. It's not possible if you just follow 10 years, then 11 years, it should go down at some point. It is going to inactive at some point. But if you see there is a plateau, like it's not going down, it's just like a horizontal line. That means time is getting invariant. Time doesn't affect the happening of the event. So then we suspect there might be a tendency for a group of subjects to getting cured or not experiencing this disease at all. So this is one line of work. Actually, we wrote a manuscript on the same data. It's still in preparation. Maybe in the next few months, we may see the light. And then I'm also working on another data set. It's called IPOP. For that data, we have a very limited sample size, around 115. This data mainly focus on the type 2 diabetes. I think we were talking about a few minutes ago before this presentation. So one line of work, there are a lot of details. I have to skip a lot of things. So it's like you have 100 people, not a lot, but the data is quite interesting. You have a longitudinal data, quite complete. And one of the papers, the authors who actually worked on this study, they published one paper in Nature, and they said that there is a tendency of a different group of subjects behaving differently. Not all the subjects just behave the same way, just the same structure, same slope and same intercept. It may not work. So maybe there is a hidden group within these subjects who behaves differently. So from clinical point of view, if you can find out that these subjects belong to this group, you may want to treat them differently. I mean, it depends on different disease, different aspect, but overall, the general thought process is like that. If there is a, the term we use is clustering, classification, something like this. So the next picture that I'm going to show, this is not the final picture or final result that we established. So this is still in the preliminary work, and there are a lot of background complications going on. But using existing methods, we find out that there is some of the patterns happening in the background who behave similarly, maybe a cluster of subjects, but other subjects behave slightly differently. So this is another line of work that I'm doing right now, using the joint modeling framework, which captures both the classification, which is unknown, we don't know it, and also taking into account that the worsening of for this one, it is glycated hemoglobin or glucose for the diabetic patient, but you can take another biomarker for different diseases. So this is another work that I've been doing with my postdoc advisor. And another interesting data, I'll be finishing soon, we have, it's called lipidomics. And this is also something new to me. I didn't have a lot of experience working with it. So the lipid profiles, just like the other biomarkers, this is also not done in the clinical practice quite often, but these lipid profiles can also convey a lot of information, especially from the internal biological point of view. Like we have the cell, and the cell needs energy to move. Like if you have a lot of sugar intake in your body, it impacts the energy. You get other complications. So something that is very biological motivated, and we have a data with we have a different subclasses of the lipids, and for each subclasses, like the numbers you can see 117, 300, or 17, these are called the lipid species. So just imagine we have around 800 something, 874 lipid data at each time point. And if you just move through longitudinally at different time points, we have many longer data sets. And if you take a look at this picture, on the top we have the glycated hemoglobin. For this one, I picked intentionally one subject. This is not random. And on the bottom, we have several lipid species going on. We have the longitudinal data at different time points. So can we use the lipid information to make a better prediction on the biomarker for type 2 diabetes? So this is something that that triggered me to work on this method. And also these lipid species, as you can see, that they have a very high correlation. But in literature, it's very hard to comment that work with this particular species, not with the other. So this makes a balance between your subjective decision versus the objective decision. Whether you can use all the species and let the data to decide how to use this information for working with the biomarker. So this is something that is quite challenged in the literature, because if you just imagine you have for one subject you have around 874 lipid species information which are time dependent. So if you just use our software, Stata, SPSS, SAS, whatever, just include those subjects, those information as a fixed covariate, your software will die. It cannot work because it violates a lot of assumption which you will not be able to see. I have a lot of results on the theoretical point of view, but need to make a balance between theory and the real application. So one point is you cannot include all those time-dependent variables just together as a fixed covariate. It doesn't work. It will not work. Or if it works, you will get misleading conclusions. So as a statistician, I should not do it, but I see people do it. So this is something we are trying to develop on the mixed effects modeling framework, but where we can include these time-dependent variables, accounting for their association, and also accounting for their heterogeneous behavior in this modeling framework. So, and finally, I want to thank the committee for the CHS innovation. Thank you, Matt, for invitation. And from my colleague, Ding Chen, Zhongzui, and Yendro, they have been always very supportive with me. We had a lot of discussion even about the work, other things. Professor Hongyu Zhao is my postdoc advisor from Yale University, Dr. Lin Sun, and Dr. Minghui Chen is my advisor from University of Connecticut. And Dr. Wei San, Joseph Ibrahim, and Jonathan, they're all the co-authors of the papers that I have worked. I'm really thankful to all of them because they helped me to build my research profile over time. Some of them has been a mentor. Even now, I always try to communicate with them. And yeah, I'm really thankful to this wonderful, very, very rich people they are to me, because I learned a lot from them, still learning, not learned. Yeah, so that's, and also, as Matt said, we have two talks in the lineup. One is December 12th, January 23. So hope the audience will try to attend these talks, and that's all for my.
So we do have time for questions, both in the room, and then Gary's monitoring the chat for people online with questions, so. Questions for Tuhi?
You can talk about this over drinks, but I'm still curious about your solution to the random effects assumption.
Sure.
This is why you have to go to drinks. So we can.
You talk about random effects more.
I'm wondering how, so like, let's say that you're gonna take what you, I mean, I'm focusing on the prostate cancer example, because most time that's what I'm most interested in. So what, if you were to try to inform clinical practice with what you're learning about prostate cancer, is it how to tell when someone is going to go from low grade to high grade? Because that will inform treatment. Is that the overall, like, is that what this establishes at the end of the day?
So the thing is, like, as a statistician, and my focus is on methodological development.
Sure.
So that this method works not only for the prostate, maybe for other methods as well. So the things that I'm trying to convey is that if you have a competing risk setup, so maybe for this case, prostate cancer, maybe for I'm working on another data, it's called CR data. It has the death information, but it also has the death due to which cause information. And also in the UK Biobank, like it uses hospital statistics. It also gives you the reason why this subject died. So theoretically, like if you just try to calculate the time from study entry to death due to certain cause, you will see that that person can die due to only one cause at the earliest time. Maybe in the clinical history or data, you will find that the date of the death may be the same for all the subjects. So the point I'm trying to make, if you have a competing risk data, it is very likely that the covariates might behave differently if you try to focus on the risk of the event due to a particular cause, and other cause is prevented by the happening of this cause. So that's why you cannot focus on two causes at the same time. And the scenario that I'm trying to say, you cannot jump from one cause to another. So that's the framework wise I'm just trying to convey. So for the question you asked, this is very difficult question. I think for the, actually, I experienced this question before. In fact, it might be possible for a subject to go from low grade to high grade. But in the beginning of this, like my discussion with the clinician and another co-author who has a lot of experience with the prostate cancer, he said, let's focus on the fact that we are just detecting the first prostate cancer that is happening. So can we focus on that? But the other thing you are saying, it might require more in-depth, analysis after the happening of the first cancer. What happens? So it might change later on. That's true.
So like cancer recurrence, is that what you mean? Like to predict?
Yeah, you can say. Yeah. Yes.
So let me ask a slightly different question. It sort of starts from where this is going and from where you want your research to go. A lot of this seems like it's really related to individual heterogeneity and unobserved heterogeneity specifically. And so what I most want to know is, because I know this isn't an issue that's deeply developed within the biostatistical literature, but there's an awful lot of work in this space within the traditional time series statistics and econometrics and within machine learning applications, because there's a lot of folks looking at co-integrated vectors where they don't maybe define them with a covariate, but think about how you look at the weights between the observables so you can find something you can basically build a proxy unobservable latent variable that accounts for that, which is very similar to finding supporting eigenvectors within the machine learning space. So how do you connect this literature, what's already being done outside of biostatistics, where there's a lot of folks spending a lot of time developing supporting eigenvectors to try to find heterogeneity within these latent unobservables?
Yeah, I think that's a very interesting question. Like if you know that eigenvectors or eigenvalues, these are related to the variance covariance matrix, right? And just imagine the variance covariance matrix gives you the understanding how one variable is related to other variable. If this variance covariance matrix give you zero value,
But
that
just,
means, yeah,
because it's also, that's one way to use them. But again, for example, the Netflix algorithm is taking that and actually building variables out of that instead of just relying on the latency and
yeah.
correlations. So
So
it seems like that would solve some.
yeah, I mean, there's two different ways.
Yeah.
So one is what you are saying. When you use the eigenvalues or eigenvectors, it focuses on estimating the variance, right? And if you are focused on the prediction purpose, suppose you have 7 values at 7 different time points. You are concerned what would happen in the 8th time point. So it
Well, it's
would
predictive
be
modeling is the key.
right.
It's what I actually thought the outcome of this was.
right. So in that case, you need to have an understanding of the subject-specific randomness. Otherwise, it will not be adjusted. So, but going back to your point, in a way, both of these are trying to estimate that variance covariance matrix, but try a slightly different perspective, or the goal is slightly different. Like when you focus on the variance covariance matrix, you just don't care about what is the prediction and what is the predictive purpose, right? So you just focus on the variance covariance matrix. So in a way, two different approach. I just don't have the, why did people, of course, so these are two different approaches, two different.
I was just curious in terms of if you had, any discussion about how they can, how you can leverage that, or alternatively at least speak to where this fits into that broader literature. Because the part that bothers me a little bit is that very often what we find in the biostatistical life sciences space often quite disconnected with what we find in the applications. If you replace, biomarker with preferences for movies or something, end up being very similar applications.
So I think one of the things that I like based on my knowledge, what I learned, like if your variance covariance matrix becomes very large, then it becomes very, very difficult to estimate the variance covariance matrix using the eigenvalues or eigenvector, whatever you have to say it. Then computationally or even theoretically, it becomes quite challenging. But when we work with the random effects component, theoretically and assumption-wise, is very more solid in a sense that we can see what's happening. But in the practical world, when we in most of the literature, if you see the vector, you'll see that they show you three-dimensional variance covariance matrix. But when you go to the real world, they might use hundreds of, thousands of dimension of the variance covariance. But I respect it and
No, I
definitely.
was just curious, we don't have to belabor the point, then I have one little question, because this wasn't about the math. It looks like that your joint model is actually different equations with shared terms as opposed to actually breaking out the error term. I've spent some part way early in my career looking at two-part models where we're breaking the error term into joint models and then using ML methods to actually estimate them. But this is just a standard approach where you've got multiple models with common terms, which means you can move outside of ML methods to actually estimate depending on what you're doing.
Yeah.
So what sort of methods are you using to actually estimate those models? And that will tell me sort of how these equations are stacked up.
There are two types of ways these methods work. So one is called shared parameter model, which I worked here.
And by the way, I mean by ML, I mean maximum likelihood method.
Yeah.
In case, they're thinking, it's not, I don't mean
Standard
machine
ML,
learning.
right?
So and another one is called trajectory model. So that's a slightly different, so where we don't use the shared Renault effects, we use the predicted version of the longitudinal into the model. So it works slightly differently, but
We don't have to apply weights to that, of course, right?
Yes. So these are slightly different approach, but each has their own merits and demerits or computational challenges. But this is one way of doing that, what we did. It's called shared parameter. So where we use the share of the random effects between this, so that both longitudinal and survival both share that association together.
This is very interesting, by the way.
Thank you, Tumi, very much. This was great. All right, thanks everybody online. I think we are done for the day.